In this video, I'm going to tell you about the anatomy of popliteal fossa. So coming to the introduction, so popliteal fossa is a shallow diamond-shaped felt at the back of the knee joint. So popliteal fossa is a diamond-shaped structure that is present over your posterior surface of the knee joint. So it becomes prominent when the knee is flexed. The popliteal fossa will be prominent when the knee is going for a flexion. So it corresponds to the cubital fossa of the forearm. So the popliteal fossa is corresponding to the cubital fossa of your forearm. And this fossa is an important anatomical region because it provides passage for the main vessels and nerves from the thigh to leg. So the nerves that is arising from your thigh and passing towards the leg will be passing through the popliteal fossa that is present over your posterior surface of the knee joint. So coming to the boundaries, the fossa is bounded supramedially. So you can see this is the supramedial structures, this is the supralateral structures, this is the inframedial structures, and this is the infralateral structures. The boundaries that is including your supramedial, supralateral, inframedial, and infralateral. And the supramedially, it is bounded by your semitendinosus and your semimembranosus. And your supralaterally, it is bounded by your biceps femoris. And inframedially, it is bounded by your medial head of gastrocnemius. And infralaterally, it is bounded by your lateral head of your gastrocnemius along with your plantaris. So supramedially by your semitendinosus and semimembranosus, supralaterally by your biceps femoris, inframedially by your medial head of gastrocnemius, and infralaterally by your lateral head of gastrocnemius along with your plantaris. So these are the boundaries of your popliteal fossa. So you can see this is another diagram representing your boundaries. So this is the main cadaver dissection of explaining the boundaries. So semimembranosus, semitendinosus, that is your supramedially, supralaterally by your biceps femoris, and inframedially by your medial head of gastrocnemius, infralaterally by lateral head of gastrocnemius along with the plantaris muscle. And coming to the floor, that is floor is your anterior wall of the popliteal fossa, and the floor is formed from superior to inferiorly by your popliteal surface of the femur. This is the popliteal surface of the femur. Next structure is your capsule of the knee joint, Next is your oblique popliteal ligament and the fascia covering the popliteal muscles. So from superior to inferior, you can see the first structure is your popliteal surface of the femur. Next is your capsule of the knee joint. Next is your oblique popliteal ligament, and next is your fascia covering the popliteal muscles. So these are the structures that is forming the anterior wall, otherwise known as your floor of the popliteal fossa. So this is another diagram representing the anterior view as well as your lateral medial view. So medial view. So you can see the same thing only, popliteal surface of the femur, knee joint capsule, oblique popliteal ligament, and the fascia covering the popliteal muscles. So these are the structures that forming the floor or anterior wall of the popliteal fossa. And next is your roof, which is otherwise known as posterior wall, and the structures that is formed by the deep fascia or popliteal fascia. So this the roof or posterior wall is formed by your deep fascia, otherwise known as your popliteal fascia. And this fascia contains the structures that is your short saphenous vein or a small saphenous vein. Next is your three cutaneous nerves, that is your terminal part of your posterior cutaneous nerve of thigh. So this is the posterior cutaneous nerve of thigh, terminal part, and the posterior division of the medial cutaneous nerve of thigh, and the peroneal, otherwise known as sural communicating nerve. So these are the structures. So one vein and the three nerves that is passing over your posterior wall or roof of the popliteal fossa. So first is your short saphenous or small saphenous vein. Next is your terminal part of your posterior cutaneous nerve of thigh, and the posterior division of medial cutaneous nerve of thigh, and the peroneal communicating nerve or sural communicating nerve. So these are the structures in the roof of the popliteal fossa. And the roof is pierced by all the structures except the posterior division of medial cutaneous nerve of thigh. So you can see in this diagram, all of the structures that is passing in the roof is pierced inside the popliteal fossa, except this posterior division of medial cutaneous nerve of thigh, so which is pierced at the superior aspect of your popliteal fossa boundaries, that is your supramedial boundaries. So all of the structures except your posterior division of medial cutaneous nerve of thigh is not piercing in the roof. So coming to the contents, the main contents of your popliteal fossa includes your popliteal artery and its branches, popliteal artery and its branches. Next is your popliteal vein. So you can see in this blue color, that is your popliteal vein, and the tibial nerve. So this is the tibial nerve and the common peroneal nerve. So you can see in the popliteal division, the popliteal fossa, the sciatic nerve will be divided into your tibial nerve and your common peroneal nerve. So next is your popliteal lymph nodes and the popliteal pad of fat. So these are the main contents of your popliteal fossa. So in addition to the above mentioned structures, the popliteal fossa also contains the following structures, which includes your posterior cutaneous nerve of thigh, that is the terminal part, descending genicular branch of your obturator nerve, and the terminal part of the short saphenous nerve. So apart from your normal contents, which includes your popliteal artery and its branches, popliteal vein and its tributaries, tibial nerve and its branches, common peroneal nerve and its branches, popliteal lymph nodes, and popliteal pad of Vag. Apart from that structures, these three structures are also present inside the popliteal fossa, that is passing in through the popliteal fossa. That is your terminal part of your posterior cutaneous nerve of thigh, descending genicular branch of your obturator nerve, terminal part of your short saphenous vein. So these are, you can see this is the diagram mainly representing the main nerves and the blood vessels that is passing through the popliteal fossa. So you can see here, this is the popliteal vein, that is a blue color, and red color is your popliteal artery, and this is the nerves. So your common peroneal nerve, and your tibial nerve. So this is the anatomical decision of the structures that is passing through the popliteal fossa downwards towards the leg. So this is the anatomic decision. So, and coming to the last topic, that is your clinical correlation or applied anatomy. So in clinical correlation, first clinical correlation is your popliteal pulse. So in order to check the pulse, so this is one of the peripheral pulse. So in order to feel the popliteal pulse, first we need to flex the knee. So flex the knee in order to relax the popliteal fossa. Then we need to place the fingertips of both your hands in the popliteal fossa with the thumb resting on the patient's patella. So the thumb should be resting on the patient's patella, and this then we can able to palpate your popliteal artery and we can feel the popliteal pulse. So popliteal pulse is the most difficult pulse to feel among all the other peripheral pulses like your dorsalis pedis and other radial artery pulses or any other peripheral pulses. So popliteal pulse is the most difficult peripheral pulses to palpate or to assess. So second condition or clinical correlation is your popliteal aneurysm. So popliteal artery is more prone to aneurysm than any other artery in the body. So clinically, the popliteal aneurysm presents as a pulsatile midline swelling in the popliteal fossa. You can see here, this is a popliteal aneurysm. Aneurysm means swelling. So you can see here, there will be a swelling present over your behind posterior aspect of your popliteal fossa. So in this diagram, you can able to see the posterolateral view as well as the posterior view. So you can see here, this the A denotes the swelling. So you can see the comparing with the both sides of your popliteal fossa of both legs. You can see here there is a prominent swelling on the midline of your popliteal fossa. So this is because of your popliteal aneurysm, and the popliteal artery is more prone to aneurysm than any other artery in the human body. So next condition is your Baker's cyst. So Baker's cyst is a cystic swelling which occurs in the popliteal fossa due to inflammation of your synovial bursa underneath the tendon of semimembranosus, or a protrusion of the synovial membrane of the cavity of the knee joint through the fibrous capsule of the knee joint. So Baker's cyst, otherwise known as popliteal cyst. So it is just a small fluid lumps that can be present over your posterior surface of the knee joint, that is in the popliteal fossa. So typically it occurs after any other conditions or any problems that occurs inside the knee joint, like your osteoarthritis or any meniscal tear like that. And you can able to feel a fullness or a tightness behind the knee, and the other symptoms include your knee pain. So the patient may complain about the knee pain, as well as we can able to see the visible swelling over your popliteal region. And sometimes the patient may also feel there is a tightness or stiffness around the back of the knee. So during movements also the patient may complain of these symptoms. So this is all about Baker's cyst. So Baker's cyst, in other words, it is known as popliteal cyst. So next clinical correlation is your tibial nerve injury. So tibial nerve injury occurs as a result of damage to the tibial nerve, so which causes both your motor loss as well as your sensory loss. So since tibial nerve is a mixed nerve, so both your motor as well as sensory loss will be evident. The first symptom is your motor loss. So motor loss occurs in the superficial and deep muscles of the calf and intrinsic muscles of your sole. So all this, like your popliteus muscles, your tibialis posterior muscle, flexor digitorum longus muscle, flexor hallucis longus muscles, and the muscles of your foot or the sole of the foot will be getting affected. And next is your sensory loss. So the patient with tibial nerve injury may present a loss of sensation on the whole of the sole of the foot and the plantar aspect of the digits and the nail buds on the dorsum of the foot. So all the nerve supply, all the branches, that is your tibial branches, superficial as well as your deep branches, will be getting affected, and there will be both loss of motor function as well as loss of sensory function over the course of this tibial nerve. So this is about tibial nerve injury. And next clinical correlation is your common peroneal nerve injury. So the common peroneal nerve can be palpated at the posterolateral side of the neck of the fibula. So this posterolateral side of the neck of the fibula is the commonly affected or injured area of your common peroneal nerve. And most frequently, so this common peroneal nerve is the most frequently injured nerve in your lower limb. And this common peroneal nerve get entrapped between your attachments of the peroneus longus to the head and shaft of the fibula. So it may either occur as a result of entrapment neuropathy. So this common peroneal nerve gets entrapped between the peroneal longus attachments of between your head and shaft of the fibula. So once the patient has been diagnosed with common peroneal nerve injury, they may present with a foot drop, which is usually painless. So you can see in this diagram, this is the normal leg, and in this, so this is the neutral position, neither in your dorsiflexion nor in your plantar flexion. But the patient presenting with the foot drop may present in a plantar flexed foot. So this if the patient is keeping the foot in this manner, means that will be normal. But the patient has kept the foot in plantar flex position. So it is not in a neither neutral position or dorsiflex position. This is a plantar flex position. So because of the weakness of your dorsiflexion of your ankle and eversion of the foot, they may present in a plantar flex manner. The foot will be in a plantar flex manner. That is known as, this condition known as foot drop. And inversion and plantar flexion are normal and the ankle jerk is intact. So in this common peroneal, this is all about common peroneal nerve injury. So next clinical correlation is your enlarged popliteal lymph nodes. So the popliteal lymph nodes get enlarged during infection on the lateral side of sole or foot. These are lying along the short saphenous vein. Short saphenous vein pierces the deep fascia to drain into the popliteal vein. So during any issues or infections, these lymph nodes will be getting enlarged. So that is your enlarged popliteal lymph nodes. So this is all about your anatomy as well as your applied anatomy and clinical correlation of your popliteal fossa. Thank you for watching this video. Please do subscribe this channel and please do share this video to your physio friends and fraternity. Thank you.